Thank you, Doug, and thank you very much, Judith, for organizing this meeting and for inviting me to speak. My brief is to talk about the current treatments that are in Australia, which basically, in a way, sets a scene for Professor Dimopoulos' talk, which is perhaps even more exciting to tell us about what's coming further. But it is important, I guess, for us to realize that there are parameters that we have to work within our own country as far as reimbursement, availability, and access. So this is a derivation of the slide of Dr. Dimopoulos already showed, which is gives you an idea of the types of treatment that we've had over some years for myeloma. And as you can see, in the past, there was not much available until the finding of melphalan and steroids, further the development of autologous stem cell transplantation in the in the 1980s with Drs. McElwain and Powles and Dr. Alexanian, and then with the onset of the three pillars of treatment, thalidomide, bortezomib, followed by lenalidomide, really all arising within the last decade. So if one were to summarize in very general terms the treatment modalities in 2013, one could say that these are the main stalwarts, mainly chemotherapy, which includes not only old and new drugs, but perhaps also newer agents, as well as importance of stem cell transplant. In addition, radiotherapy, the treatment of bone disease, including the use of bisphosphonates, surgery, and vertebroplasty, psychological counseling, palliative care, and support groups. Indeed, one of the important elements of management is support groups such as the one we are holding today. But in the interest of time, obviously, I'll be concentrating on chemotherapy, which I am sure is your main interest today as well. So I'm just going to cover very briefly the management of asymptomatic myeloma, because essentially Jane has already told you, and indeed Professor Dimopoulos has also said to you that many cases of asymptomatic myeloma may not require treatment for some years. So Jane's already told you the criteria that you diagnose asymptomatic myeloma as opposed to active myeloma having those crab features of end organ damage. And hence, as we manage asymptomatic myeloma, the management basically consists of very carefully monitoring the features which can help us define when active myeloma has occurred. And if any of those features occur, then we would move on to treat that disease, which will form the basis of the rest of my talk. However, if those features are not present of high calcium, renal impairment, anemia, or bone abnormalities, then we would simply continuing monitoring the patient at various frequencies, but most commonly perhaps every 3 months. The main underpinning finding that really establishes modern day treatment since the since 1990s is the finding that high dose therapy and autologous stem cell transplant treatment is the therapy of choice with patients with active myeloma, and here I say age 65 years or below. Now, it is very important to realize that age is a biological age. And by that, we actually separate or divide patients into those who are transplant eligible and those who are transplant ineligible. Now, when I speak to patients, I always say that doesn't mean if you are transplant ineligible, you are any way worse off than those who are transplant eligible. And in that sense, the word eligible is not really such a good word. The main reason I say that is it simply indicates what best treatment is for you. So if you are transplant ineligible, it doesn't mean that you are in any way inferior from our point of view to one who has a transplant. It's just that we know that treatment that does not involve a transplant is in fact will provide a better prognosis for you. So I really want to get this very clear in your minds. And in addition, the assessment of eligibility, for want of a better word, is, as I said, by biological age. So we routinely transplant patients up to the age of around 70 or even slightly more if someone is very fit. In contrast, if someone is in their 50s, for instance, but has a large number of comorbidities, such as heart disease or previous stroke, for instance, we may elect not to transplant them because we know that they won't do as well with a transplant, but rather it's better to give them other drugs. So here are the two studies that I'll simply mention very briefly, the French and British study some years ago, which established that for patients who are able to have a transplant, those are predominantly under the age of 65, that doing a stem cell transplant, an autologous stem cell transplant, is what is preferred. So what is, I will now summarize basically what I've said in the last few minutes. This is a basic schema whereby we look at the patient, first of all, establishing that he has active myeloma, he or she has active myeloma, and start them on some chemotherapy, whether it be for a non-transplant eligible patient, which carries on to attain the highest level of response, whereas for someone who can have an autologous transplant, to undergo autologous stem cell transplantation, in addition to look after their bones, particularly using the drug bisphosphonates. Clearly, there is the issue of consolidation and maintenance treatment, which I'll come to in a moment, and in addition, inevitably, the disease does relapse, and hence, as I'll say to you, in fact, one of the main parts of treatment of myeloma is indeed treatment of relapse disease, and that will be the use of either different or newer drugs. So I made this slide a year or two ago now, and it would be said that there are three current pillars of treatment, and that would include thalidomide, lenalidomide or Revlimid, and bortezomib and Velcade. And clearly, the information on this slide will evolve with the development of more agents. Thalidomide and Revlimid or lenalidomide are common in that they are immunomodulatory drugs, whereas bortezomib or Velcade is a different type of drug. It's called a proteasome inhibitor. I won't go through the science of that because I don't think that's where you've come to listen to me to say, but it suffices to say, however, that in both groups of these drugs, and these are the three drugs, all three are available in Australia, there are going to be more drugs that are coming within the same groups. For instance, the next up-and-coming one for immunomodulatory drugs is pomalidomide, of which Professor Dimopoulos is one of the main researchers in the field. And in addition, in the proteasome inhibitor group, cafizimib and an oral drug called MLN9708 is coming forth. And these are used in conjunction with alkylating agents, which is a particular type of older chemotherapy drug called cyclophosphamide in particular, and also melphalan in transplant-ineligible patients, as well as steroids. So the upfront treatment pathway can be summarized as such, and I'm aware of time, so very quickly, for those who undergo transplant, they will have, first of all, an induction phase of the chemotherapy, and now in Australia we have both thalidomide and Velcade available, followed by stem cell collection and autologous transplantation, and followed in general by thalidomide maintenance for 1 year as a result of the Australian trial of Dr. Andrew Spencer that Dr. Dimopoulos mentioned just now. Whereas for the non-transplant patients, we also have options, and that is the use of Velcade or thalidomide in combination with melphalan and prednisone, otherwise known as MPV and MPT. And it is important to note that tolerability is an important factor in these patients as to how long they can go for and whether they can receive, how long their maintenance can go on for. In addition, supportive measures are obviously important for bones, infection, and so forth. So the three, going through those agents that we do have available, thalidomide is an immunomodulatory drug with multiple modes of action, in particular, in addition to modulating our immune response towards the tumor, it also inhibits the generation of blood vessels, otherwise known as angiogenesis, and induces the death of cells, which is called apoptosis. There is synergy with other agents. It's given such as cyclophosphamide and steroids. It's given as a tablet. It's safe with renal impairment, but there are a number of toxicities, including neuropathy, constipation, thrombotic events, so clots, as well as feeling very tired and somnolent. It is, where in contrast, lenalidomide, which, as I said to you, is derived from thalidomide, it's the same group of drugs, It's more potent than thalidomide with a similar mode of action. It has, again, synergy. It's given orally by a tablet. Some of you will be on it, being given one tablet a day for 21 days out of 28 days. We need to dose reduce in renal impairment or when there is toxicity, and those toxicities mainly include reduction in your good blood counts, whether it be white cells or platelets or thromboses. And in Australia, Revlimid at present is available from the first time you relapse. It is not yet available at induction, so at the beginning of treatment. And finally, the third drug that is in our armamentarium is bortezomib or Velcade, as I said, a different class of drugs, often given intravenously, especially when it was first used, but now more and more commonly given subcutaneously. And so subcutaneously is just an injection under the skin, as many of you will receive or will be receiving. And the main reason for doing that, in addition to the fact that we don't have to put a cannula in your arm, is because there is a reduction in the toxicity, particularly of neuropathy. The usual schedule, and some of you will be very familiar with this, is something like Monday, Thursday for 2 weeks out of 3. That is days 1, 4, 8, 11. But more and more we are giving weekly schedules for some patients, especially to reduce toxicities in the more frail patients. It's particularly useful in renal failure, and this is a very important point. If someone has renal impairment in myeloma, bortezomib and related drugs have been shown to be particularly effective in reversing or at least improving that renal failure. The toxicities are a different category again, one of the main ones being peripheral neuropathy. There is a low platelet count is a very important issue, and we obviously check the platelet counts. GI upset, gastrointestinal upset, so nausea, etc., as well as low blood pressure. There are specific considerations when we choose what particular drug is best for you in a particular situation. So I will mention some of these. I already said for renal impairment, bortezomib is preferred. If there is recent clots or other cardiovascular events, again, bortezomib is probably preferred because thalidomide in particular has an increased risk of clots. Jane already explained the use of cytogenetics, and along those lines, sometimes patients are thought to have a more high-risk disease, and bortezomib and lenalidomide or Revlimid-based therapy is thought to be more effective than thalidomide. And again, neuropathy is one of the major issues in treatment, and lenalidomide-based treatment has less neuropathy than thalidomide, whereas bortezomib therapy, we would either modulate to once a week or give subcutaneously. Bone disease, bortezomib does have an increase, a specific effect on bone, and hence can be one of the treatment of choices for that reason. I've already said this, that patients who can have a transplant should have a transplant, but we do not advise tandem transplants at this stage. And how do you get a transplant? So in very simple terms, you get given cyclophosphamide or GCSF. So cyclophosphamide is a chemotherapy. GCSF is a white cell inducing hormone which is injected, and some units only use GCSF and not cyclophosphamide, using a procedure which looks very much like dialysis, but it's not. You get blood from one arm, take the stem cells out, the stem cells are then frozen, and later on the patient gets high-dose chemotherapy, the idea of which is to wipe the marrow of the myeloma, and the stem cells then get infused back. And so this is what usually happens. You get melphalan at the stem cell transplant, and then an infusion of stem cells. So the melphalan wipes out the residual myeloma and normal bone marrow, followed after 9 to 10 days by recovery of the blood counts due to the repopulation of the marrow by the reinfused stem cells. I will skip this slide in the interest of time. That was just to show you that it's being very commonly done. What about non-transplant eligible patients? There are significant improvements. The backbone of induction therapy is very similar, the 3 pillars, but at present, only thalidomide and Velcade are reimbursed for this situation in the induction treatment in Australia, namely, and so very commonly used therapies are a combination of melphalan, prednisone, and thalidomide, or melphalan, prednisolone, and Velcade. And often cyclophosphamide is used instead of melphalan. In my practice, I mainly use cyclophosphamide, but it is used interchangeably. I'll skip over the next few slides in the interest of time. These next few slides simply show you that for transplant ineligible patients, MPT, that is better than giving someone half a transplant or a reduced intensity transplant. And the same findings were made by a number of groups demonstrating, as I said to you, just because you are non-transplant eligible doesn't mean that there is not effective therapy. This is the use of melphalan, prednisolone, and Revlimid, demonstrating the significant improvement with, in fact, Revlimid maintenance, which is a different issue, and I'll come back to that in a second. So in essence, the slide that I showed you for patients who are not transplant eligible, you use an alkylating agent like M or C, a steroid agent such as prednisone or dexamethasone, together with thalidomide or Velcade at this stage in Australia. This slide, and I'll just simply talk to it rather than you going through the figures, it's important to realize that the toxicities of patients who are elderly, and as well as the discontinuation of the drug in these regimes are in fact the worst issues for those patients as far as mortality is concerned. So one, we should not cause toxicity in our wish to increase the response. At the same time, we should not discontinue drug and be too, shall I say, Minnie Mouse in giving drug, or Mickey Mouse, because we need to try to attain a good response. So it's a very important balance for the doctor to encourage you to continue and yet not give you too much toxicity. And that's clearly shown in this meta-analysis that is looking at a large number of trials. And as you can see, the impact of new therapies has not only increased the total response rate, but also the rate of complete response. So maintenance, and very briefly, I think I've gone over time already. So in essence, again, we talk about the same three pillars: thalidomide, bortezomib, and Revlimid. Thalidomide has been shown to improve overall survival in 3 out of 6 studies in those patients who've had an autologous transplant. And one of these includes the Australian study that Professor Dimopoulos mentioned. Bortezomib, the overall survival, again prolonged, including the HOVON study from the Europeans. Revlimid, overall survival, also prolonged, and Professor Dimopoulos showed you the pictures that I won't show you here, as I knew it will overlap, and that would include the American study as well as the French study, actually mainly the American study, the CALGB study. So how long, if one were to give maintenance, what is the duration? That is a question. And we have picked a timing that is 2 years at the moment. And one of those issues is to balance what is the possible benefit of maintenance treatment against the possible toxicities. And in the usual, in the general consciousness of myeloma doctors and patients, there has been an increased concern with second malignancies. And that has been attributed to lenalidomide amongst other agents. I would like to mention to you that in the analysis, the percentage has been established to be around 5 to 6%, and there is, at present, in fact, no evidence that it is increased compared with patients who are not, in general, being treated with other agents. And in fact, it is the alkylating agents, mainly melphalan and cyclophosphamide, which are thought to be major contributing agents to these second malignancies. And hence, overall, the benefits would seem to us to outweigh the possible risks. The aim of increasing longevity from myeloma would overcome the possible risks. I won't go through this. These 3 slides, these 3 graphs simply tell you that in patients who have non-transplant eligible patients, that there have been improvements with the use and maintenance. But this is a wordy slide, but it tells you the current recommendations in the Australian myeloma guidelines. Essentially, we're following the Australian trial, giving thalidomide and prednisolone for 12 months. However, the role of bortezomib and Revlimid in maintenance still to be considered and as yet not reimbursed. When it comes back, and this is one point I want to make, that it is to be expected, shall I say, that myeloma can come back, and it's important to realize that a large part of your survival may be after your first relapse. So don't be despondent when your myeloma comes back, because what we do at your relapse makes a big difference. Almost all patients eventually relapse. There's a highly individual approach to the treatment of choice, and the options include more of the same and various combinations of drugs that I've already told you. But in very simple terms, I can say we can use salvage therapy incorporating novel agents not seen before, repeating the initial regimen if the relapse occurs more than 6 months after the cessation of the initial treatment, and if a patient has had 18 months without treatment after the autologous transplant, you can consider giving the autologous transplant again. I will skip that. This is simply to tell you we try to give drugs that you have not seen before, because the idea is that your myeloma cells are very clever. They can overcome what you've seen before. People always ask, what about allogeneic stem cell transplant from someone else? Well, it is still considered investigational and should ideally be performed in the setting of clinical trial. And for young patients with high-risk disease, sometimes we would consider it. What is high risk? This is a whole panel using the investigations that Jane has mentioned to establish high risk. I'm happy to talk about this at the break. And the fact is, risk-adapted therapy at the moment is not clearly, we don't really know what we're doing, because we do not know whether good myeloma will always remain good and not bad myelomas, according to those criteria, behave badly all the time. And finally, with supportive care measures, we look after also impaired immunity of giving Intragam, for instance, renal impairment with dialysis and some special filters for the light chains. I've already mentioned bone disease, and toxicities will be is being covered by Tracy King and Professor Joshua in the breakout groups. This slide I borrowed from Professor Joshua, which is our current algorithm in Royal Prince Alfred Hospital, and we share patients very much with Concord Hospital, and here you can see Professor Joshua has written out what we are meant to do. We do what he tells us to. So there are various clinical trials using new agents which are available, and the emphasis is on clinical trial, which Judith will talk to us about. There are many more agents that Professor Demopoulos will talk about. And finally, I would just refer you to the current treatment paradigm for myeloma in Australia, which is available on this website. Thank you very much.